Okay, well, why don't we get started? So thank you so much for joining us. My name is Mike Gardner. I'm an orthopedic surgeon at Stanford University. And myself and some colleagues started a new service where we've heard over and over again the difficulty that parents and kids have with scoliosis in terms of figuring out the best treatment, getting information, figuring out about physical therapy and radiology, et cetera. So we started the National Scoliosis Clinic, and as one of our webinars, we're extremely excited today to welcome Dr. Jesse Sandberg, who is an expert radiologist, particularly in the pediatric space, and works at Packard Hospital here, affiliated with Stanford. And so, as you know, probably radiology is a major component of scoliosis: initial diagnosis, ongoing monitoring, effects of treatment, et cetera. So we base a lot of what we do on radiologic measurements and tests and things like that. And so again, keep in mind, Jesse, radiologist, and so when you're thinking of questions throughout here, there'll be some time for some questions at the end. But please feel free to think of questions along the way, and we'll get to these at the end. So without further ado, Jesse, great to have you here, and I'll turn it over to you.
Awesome. Thank you for that great introduction. Let me just share my screen really quickly here. All right. Hopefully you're seeing my screen. So, again, thank you for that warm introduction. I'm Dr. Jesse Sandberg. I'm a pediatric radiologist at Stanford, and I'm the interim chief of pediatric musculoskeletal imaging. So a quick outline of what I'll be really talking about today. And first is the role of pediatric radiologists. As I'll be honest, not many people think about pediatric radiologists, for better or for worse. And I will then talk about diagnostic tests to evaluate for scoliosis, some secondary imaging studies that might be performed, some follow-up imaging during treatment, and really answer any questions you might have. And, for this talk, I'll not go into any detail on specific pathologies. And of course, I'm not an orthopedic surgeon, I'm a radiologist. All right, so first off, what makes up a pediatric radiology department? So it's made up of not only of pediatric radiologists reading your child's scoliosis radiographs, but is made up of many different people, which includes radiography techs, nurses occasionally, a lot of administration, including front desk staff, schedulers, managers, room assistants, which all of you have probably had to work with in the past. And then the all-important film librarians. These are the people that you get your films from if you want to take them home. And for us radiologists, it's very important medical IT to help us with any IT issues. So a quick aside about film librarians, these are people, if you want to copy your child's images, whether it be a scoliosis radiograph or any other imaging, these are the folks to make it happen. It's generally a person assigned in the radiology department. You could just ask the front desk person. However, at some centers, if you're at a particularly smaller radiology department, a smaller hospital, this responsibility will be lumped into the job of medical records, just the medical records folks. And there's generally guidelines on the website where to find those people and what number to call. So in terms of my job, a pediatric radiologist, we're the doctors who read all types of medical imaging for children. And this doesn't only include radiographs, but CTs, MRIs, ultrasound, fluoroscopy, nuclear medicine, and we're often, especially in the orthopedic world, a little bit behind the scenes, especially in the care and evaluation of scoliosis. You'll probably likely never meet the radiologist reading your scoliosis films. But I do want to say, as a pediatric radiologist, I do see patients and families daily, especially for ultrasound and fluoroscopic exams. And a fluoroscopic exam is like a real-time x-ray where we have the patients drink something or something along those lines. And doctors of all subspecialties consult with us on the results of your child's imaging study. I feel like half of my job is talking to the referring physicians and discussing the results and next steps and things of that matter. And if we are, especially at large academic institutes, we help with multidisciplinary care conferences with multiple subspecialists to decide what the next best step is. There is one myth, and I still get this today by family and friends that are not in medicine, that radiologists, we just sit, alone in a dark room. And this is really false. Almost all radiology departments, especially academic centers, work in what's called open reading rooms and with the lights on, to a certain degree. This is an example of where we read our CTMRs, just going up and down the hallways here. With our very good residents and fellows, and they allowed me to take their picture here. So we could ask each other questions, consult, and things of that nature. So we're not like closed off by ourselves. So, we are general radiologists. We read all medical subspecialties. I could be reading musculoskeletal imaging, oncology imaging, neuro, a lot of different imaging. But, unlike adult radiologists who generally subspecialize in a certain section, we generally are generalists. However, we tend to subspecialize in certain interests, such as, I subspecialize in musculoskeletal imaging. All right, so moving on from that little intro, let's actually talk about the diagnostic test to evaluate for scoliosis. And these include the standard X-ray, or what we call standard radiography, something called EOS Imaging, which I'll get into, and this clumps section, what's called cross-sectional imaging, and this really includes CT and MRI. So let's start out with standard radiography. It's an imaging technique using X-rays, which is a type of ionizing radiation. I'll get into that. And it's a great modality to evaluate bones. And a general radiography suite will encompass a standing platform here, where if your child needs a standing type radiograph, they'll stand and take an image there. Or if they need to lay down, there's a table to do that. Now, for your scoliosis image, how the field of view should look like, how long the image should be, it should be from the mid-face region to the upper thighs. And this is an example on the right. And this allows evaluation of the entire spine and the pelvis. And, again, I'm not going to get into too much of the pathology, but looking in the pelvis can help the orthopedic surgeons determine how the scoliosis affects the tilt, or, how the pelvis lies within the entirety of the skeleton. And so in terms of patient positioning, this could either be done standing, supine, or, in other words, laying down, sitting, either in a wheelchair or a chair. And this all depends on your child's ability to cooperate either with standing, laying down, or sitting. And generally it's in the order form, what type of positioning is desired. So what are the typical views you might expect when you go into a radiology suite? So you can get a frontal view, or the radiology term is an anterior-posterior view, for anterior to posterior, where the X-rays are getting emitted. And a lateral view, where we take a view of the spine in the lateral position, so we could see the curve of the spine in the lateral position. Bending views, where we not only get imaging in what we call a neutral positioning, just comfortably standing straight, but asking the kiddo to lean maximally to the left or right. We also might obtain what's called an in and out, quote unquote, brace view, where X-rays will be obtained both with a brace on and a brace off. And a brace on X-ray, you can't really see it. The only part we see is the actual strap here, where the snaps are. All right, so how, as a radiologist, I know what I'm looking at? Like, there's all these measurements, all these numbers, and that's really all for orthopedic surgery and all orthopedic imaging. But we have two great books here, Measurements and Classification and MSK Radiology, and this Spinal Deformity Study Group book that we have in all of our reading rooms, and actually as a PDF version. So it's a really great resource, and all measurement techniques are standardized. So we're just not making up numbers and measurements. It's all standardized. So the most important that I think all of you are probably aware is the Cobb angle. This is the most important angle and the most well-known measurement out there. And it's performed on a frontal radiograph. And this, really assesses the lateral spinal curvature of the spine. And this is, as a radiologist, We have multiple tools on our what's called a PACS platform, where we view the images, where we can make these measurements. And this is, when we say someone has scoliosis, this is generally what, it's the Cobb angle is what we're measuring. In a lot of the world, at least in radiology and in most orthopedic worlds, we consider greater than 10 degrees to be considered quote unquote diagnosis of scoliosis. It doesn't mean if they have less than 10 degrees, it means there's no curvature, but we will use sometimes different terminology if it's less than 10 degrees. Oftentimes I'll say the patient has, dextro curvature instead of dextroscoliosis. And then the orthopedic surgeon will decide how to proceed from there. Now, besides from the Cobb angle, which is obviously the most important, there's many, many, many other measurements out there. And I won't go into detail how I measure, but what I am looking for in these measurements is what's called coronal balance. That means if there is enough of a scoliosis, is the patient leaning one way or the other too far? Okay. And then something called sagittal balance, which basically means, is the patient leaning too far forward or backward because of their scoliosis? And in the lateral, there is all these different medical names. Kyphosis is the curvature of the thoracic spine. Lordosis is the lumbar spine. So sometimes you could also get too much of those, causing issues. But I'll just leave it at that. But I am assessing for that as well. I'm also assessing, I mentioned it before, something called pelvic tilt. And sometimes a scoliosis will cause the pelvis not to lie horizontal in comparison to the earth. And I will measure that as well. This can also cause, lower extremity issues as well. And so that's why we're kind of looking at all these different things. It's kind of a cascading effect. When you have certain issues with your angles, it could cascade down to the pelvis and then the lower extremities, and obviously cause pain for your kiddos. All right, and so what am I actually measuring on the bending views? Well, I'm basically measuring those Cobb angles. I'm just measuring it when, the patient is in different positioning. And this really assesses whether the scoliosis is quote unquote static, or is it mobile when the patient bends maximally to the left or right. And this might guide orthopedists on bracing and possible surgical planning. And then these brace views, it's more a guidance for the orthopedist. Does the scoliosis measurement change when the brace is in place or not? Is it actually doing its job? Does it need to be adjusted? And many other questions. So to sum that all up, the orthopedists use all these measurements to determine the best course of action for treatment and follow-up strategy. And some of these questions, does the brace need to change? Does the physical therapy guidance need to change? Does the follow-up imaging interval need to change? Might think about surgical considerations. And of course, for pre-surgical planning, if that's the route that is going to be taken. This is an example scoliosis imaging report from my institute. I obviously made it anonymized, but you'll have the title, the history of your kid, the comparison imaging, which I'm always comparing to the prior, sometimes multiple priors. The procedure comments, how we perform the procedure, the actual findings, which includes, the lateral spinal curvature, the Cobb angle, the change from prior, and some other things we're looking for, and a final impression. Of note, at some institutes, the orthopedic surgeons request us not to include the actual measurements in the report. And so if you don't see actual measurements in your report, don't be alarmed. We have performed them, and so as your orthopedic surgeons. It's just been requested to not have us both do it at the same time. All right, so there are some inherent risks, as all of you are aware, in terms of any ionizing radiation. I know this is a stressful topic when obtaining imaging study for your child. I'll be honest, it's a very long topic, and it's really outside the scope of this talk in terms of a long discussion. But I will say, I will discuss it briefly here. So, it does use ionizing radiation. As we know, there's a small inherent risk. It is a very, very small dose with the current technology we have today. Now, This chart over here is taken from a source that I use when explaining to patients and families about radiation dose. Now, everybody is exposed to background radiation. And so on the left here is some radiographic examinations which uses radiation. And this is the equivalent days it will take to obtain that radiation if you're just out in the outside world due to background radiation. So for instance, if you're just going to do a one view chest radiograph, if you just take one, you'll get the same amount of radiation in 2.4 days just living your life. In terms of physics, if you get a lateral view, it's a lot more days. I don't want to go into that, but in terms of mammography, if you to get one mammography study, that's 1.5 months of background radiation dose. And you can see how it kind of increases where, abdominal CT is 2.5 years. So, in terms of a scoliosis series, using a standard radiography technique, you could think of it as, maybe similar to slightly more than a 2-view chest film. Now, however, our standard radiography technique for scoliosis uses a much lower dose than a chest radiograph. So it is somewhat a little harder to predict, but you could think of it like that. Another way to think about it is a round trip flight from San Francisco to Boston. Now, if you take that, it's the equivalent of a 2-view chest radiograph, more or less. Okay, so I think many people have traveled, probably a long cross-country trip. That's the equivalent of a 2-view chest radiograph. And so that's basically what your child will receive. And so over the course of treatment, depending on the severity of your child's scoliosis or follow-up, maybe they'll get 10 scoliosis. I've seen it up to 25. It kind of all depends. So even if you add up all of those, it is much, much less than the threshold for cancer, such as leukemia. I mean, it's much less than even a single abdominal CT scan. But segueing into an imaging method to even further reduce radiation is something called EOS imaging. Now, EOS, I know in medicine we have a lot of acronyms, but this is actually not an acronym, it's a company name. And this uses an ultra-low dose X-ray imaging technique. It simultaneously takes a full body, or can take a focused frontal and lateral view of the entire skeletal system, actually. So it's pretty cool. No need for repositioning in between views. It's mainly used for scoliosis assessment, but it's also used at my institute and many for lower extremity leg length assessment, which I'm sure some of your children get as well, in addition to scoliosis assessment. Now, patients can be sitting or standing for this imaging technique. And as I mentioned, it uses significantly less radiation than standard radiography. It's approximately 1/3 less radiation. And this is what one of these cool imaging systems look like. It's a pretty large system. It's generally pretty colorful. They plop it into a room. They have a stepping stool to come in. The child gets, position, and then it's a quick X-ray and you're done. Now, it's not available at every imaging center. It can be quite costly to start the program compared to standard radiography. From the picture, it is quite large, and so it needs a large room. And in general, if it is available at a hospital system, they'll only have one unit at a single imaging site. So it's potentially at a remote location from where the clinic is or from where your desired location is. And there's occasional maintenance issues that sometimes arise with these. There is some other downside because it's a much less dose. I'm unable to see all the anatomic structures as well. And the images are more quote unquote noisy. It's just we don't use as much dose, more or less. So, as a radiologist, when using EOS, I only could reliably see the general bony detail, but when we're getting this for scoliosis, that's the general point. So I won't be able to see random incidental findings at times. I've obviously picked up things, but it's not guaranteed I will pick it up using the EOS technology. So it's understood, with the orthopedists and the radiologists, the main purpose of EOS imaging is the general bony anatomy, scoliosis, leg length, things like that. I just will, as a caveat, it still uses radiation, but it's an exceedingly small and essentially negligible dose. So at my institution, a large majority of the scoliosis series are performed using these EOS system. I know it requires some maintenance here and there, but it's really good and reliable. And, as I mentioned, everybody understands the limitations of EOS. Last, quickly, is the cross-sectional imaging. And, this is CT and MRI. CT or computed tomography, it's rarely ordered and performed for standard scoliosis assessment. It has, as I mentioned, that, radiation chart, it has a lot more radiation. You can see a lot more bony visualization. But, again, it's at the expense of radiation. It's occasionally performed for pre-surgical planning in really high complex cases, though. MRI is occasionally performed in patients with scoliosis. This, because MRI has superior soft tissue contrast, I could really see soft tissue detail more than CT and radiography. And so often this will be performed if there's a worry if this is not idiopathic scoliosis, if this is caused by some pathology, and they need to assess whether something else is going on, and to assess for other associated pathologies such as tethered cord. Is a question I get sometimes is CT MRI an effective method for diagnosing scoliosis? The answer is yes and no. I mean, it can diagnose scoliosis, but only assesses in supine position, laying down position, because that's how you obtain the CT or MRI. And orthopedic surgeons often want to assess scoliosis when standing or in multiple different positions. And as I mentioned, CT uses much more radiation. MRI of spine is a long exam. It could often take a lot of time, so it's not ideal in young kiddos who require sedation. MRI costs more. And then, when should I consider MRI instead of other diagnostic tests? As I mentioned, if we want to assess for pathologic cause of scoliosis or look for any other associated conditions. All right, so some secondary imaging studies that might be performed besides the one I already mentioned. So scoliosis can change as the children grow and mature. Thus, assessing for skeletal maturity can help the doctor determine whether the scoliosis will change more or not. So some orthopedists will wait to perform spinal fusions until after skeletal maturity. If the scoliosis is severe enough, obviously they will discuss with you about performing surgery earlier. So two common radiographic ways to assess for skeletal maturity is the bone age via hand radiograph, or what's called Reiser staging, which can assess on frontal scoliosis series radiography. So a bone age, it's just a simple frontal X-ray of the left wrist, hand, and fingers. And we're basically, looking at the bones and growth plates of the X-ray and compared to standard atlas of bone development of kids of the same gender and age. So bone age is measured in years and months. And, report will also give standard deviation above and below the mean. So it's considered mature when all growth plates closed and bone morphology is similar to that of adult hands. So in this example here, this is a kiddo that's 13 years, 9 months based on a standard atlas. And, this is a growth plate here. Basically, the bone should go all the way to the end. And these are growth plates where it's some what we call lucency, or where there's no white bone there. And this is where your child's bones grow. And then bone age X-ray often is also ordered by other people like endocrinologists for kids with early or delayed puberty or in small stature. And this is just the Reiser grading system, which can actually be assessed on the scoliosis film based on the degree of ossification of the iliac crest. So finishing up here, imaging follow-up while receiving treatment for scoliosis. This is really the art and practice of medicine. Each pediatrician and pediatric orthopedist has their own method and style of treating and following up scoliosis. It varies so widely here. So I really didn't want to go into detail on this because, your orthopedic surgeons are the true experts, and they utilize all their information we provide to them to make the best determining for your child. And it generally does depend on the severity of the scoliosis at diagnosis, and as follow-up progresses. But you should expect imaging at least until skeletal maturity, what I've generally seen at my institute. These are just some general guidelines I put in here in terms of what you might expect based on the Cobb angle. So, if they have a mild scoliosis, they'll get followed with radiography, sometimes every 3 to 6 months, sometimes actually just yearly. And then, they might suggest physical therapy, possible bracing. And, at some places, if it's just a small scoliosis, the pediatrician will just follow these patients. If it's, more of a 20 degrees, greater than 20, less than 40, a brace will be encouraged. Scoliosis series radiographs might include views with and without the bracing, so more imaging. And then, pediatric orthopedists might be involved in these cases. In greater than 40 degrees, consultation pediatric orthopedist is definitely encouraged. The brace is more recommended in these cases, might get more imaging follow-up. And then these are the ones where there might be some discussion with your surgeon for possible surgical correction. And then these are your x-rays after surgical correction. You see a prominent scoliosis here, and then after fusion, you'll see a decrease in scoliosis in here. And this is an example of a Reiser stage 5, which I misspelled there. All right, so we're looking for on these follow-up scoliotic curvature, hardware complication, is it intact? And then, the spine above and below the fusion, make sure it's nice and healthy there. So in summary, pediatric radiologists are often the unseen doctors helping taking care of your children in the treatment of scoliosis. We are really here to assist in helping pediatricians, pediatric orthopedists, surgeons, really anybody in image and study guidance and interpretation. The radiation dose is very low, even over the course of treatment. EOS imaging for assessment of scoliosis is the most preferred method, and it really provides the decreased radiation dose. MRCT is generally not used as the primary assessment for scoliosis, but can help in finding associated abnormalities. Expect at least yearly scoliosis series until at least maturity. And your doctor might order a hand radiograph to assess bone age, maturity. And then severity of scoliosis really dictates follow-up and treatment recommendations. So I'll open up to any questions now, and thank you for your attention.
Fantastic, Jesse. Thank you so much. We'll maybe get to questions in just a second. Just a quick word of the National Scoliosis Clinic. So we have, again, we've heard and seen from hundreds of parents the difficulties that people have in the current system that can range from getting a bunch of x-rays, difficulty getting in to see a specialist, wanting a second opinion, getting good information, etc. So we've designed a series of things, tools and services for parents and their kids. Again, that involve scoliosis specific exercises and Pilates that have been shown to decrease curve progression. Live information sessions from Dr. Voorhees, one of our pediatric orthopedic surgeons on our team, live sessions with brace makers for more information. Really, ultimately, we like to have kids be able to avoid unnecessary surgeries that can be identified early with at-home screening technology that we're working on as well. So a lot of exciting things. We really hope to revolutionize the scoliosis system that is very archaic and can often be just difficult to manage and sort out. So maybe, Jesse, here's one. How do you assess scoliosis in x-rays when the patient has a lower limb discrepancy? So is there any consideration for limb length or pelvic tilt or anything that gets accounted for?
Yeah, and that's a great question. And I kind of alluded to that briefly in one of my slides here, but the whole spine is connected. So if there's an issue with leg length, it's going to affect the pelvis, it's going to affect the spine. It's all connected together. So absolutely. So oftentimes, if there is a leg length discrepancy, now we've instructed not only our techs, but oftentimes our pediatric orthopedic surgeons are acutely aware if there's a limb length discrepancy, and we'll put in the order form, please put block under patient. Oftentimes our radiology suites are where the pediatric orthopedists are, so they're able to directly communicate with each other. But yes, it is pretty standard for us to put a block under the foot so we get a neutral positioning of the lower extremity so we could fully assess the pelvis and the spine without the leg length discrepancy affecting it. Absolutely. So we do instruct our techs to do that if they see that. we've promoted with our orthopedic surgeons to put that in the order form and communicate that with us. As a pediatric radiologist, I'm not there in person often. All these where the radiology x-rays are performed. We have many, many sites, and a lot of big institutes do. So we'd have to do a lot of training with our staff on how to perform these. So that's a good question.
Yeah, good, great answer. So here's a good one. John, great question. So when you're measuring a cob angle from one series to the next, and then kind of similarly, how do you decide which vertebral body to use as the reference points for each end? And, when you get one 6 months later, do you make sure to use the same vertebral bodies as the previous, or do you kind of pick the most appropriate on that given study?
That's also a very good question. And there is some guidance in those textbooks I used in the beginning. And it is very standardized on how to measure your standard idiopathic scoliosis, where you measure from a top of vertebral body to a bottom. And then when you do the lower scoliosis, you measure from that same vertebral body from the top to the bottom. In terms of the same vertebral body, I always look for the biggest scoliosis. So almost always it will be the same vertebral body, but every now and again it won't. So like in this example here, you want to measure this cob angle here, I would say that vertebral body has the biggest, it's where the curve kind of maximally bends there. And then, this vertebral body here is the maximal bend up. So I'll measure from there to there. In 6 months, if that doesn't make my largest curvature, then I won't use that vertebral body. It's many things. You are correct. That's a good question. Many things in radiology, we do want to measure the exact same things when we're comparing like lesions and kidneys. We want to measure the exact same way. But for some of these musculoskeletal measurements, we want to get the most accurate measurement for that particular study. And sometimes the technique of how the x-rays are performed are slightly different. So I look at each study individually, but obviously I compare the cob angles on both,
Great.
if that makes sense.
Yeah, for sure. That's great. So Z, good question and quick comment here. So we don't live near Stanford, but in another state, do you provide second opinion service if we may with the x-ray? Yeah, so just to clarify, the National Scoliosis Clinic was born by several of us here at Stanford, but we're now a national clinic. And so we've got telemedicine specialists that we've trained to be experts in scoliosis and provide guidance. So you don't need to travel and go see a scoliosis specialist in person, especially if you already have the x-rays, which is great. You can you can sign up for an appointment with one of our providers in whatever state you live in. And they can review, they can send you to get a brace, they can provide guidance, and they can do anything that needs to be done until, and fingers crossed, hopefully not, but until the point a patient needs surgery, and at which point we refer to a local orthopedic surgeon. So that's exactly what we're set up to do, and happy to provide a second opinion.
Yeah, and in general, like that's a great answer, and that's at Stanford, we do imaging, second opinions all the time. It is our common practice though that you had to be seen by someone at Stanford as well. It's mainly because we don't know who do we send, who do we talk to about the findings. So generally when people come here for second opinions, they're actually also seen by a pediatric orthopedic surgeon or anybody, and that could be telehealth too. So that, yes, to answer the question about Stanford.
Yeah, great. So next, Elizabeth, another good one. Can I request my daughter doesn't have x-rays taken at every appointment? She's 15 and currently braced, so I don't think it's progressing. Is it more important that she gets a film? So this is tricky. So this gets into what Jesse touched on of the art of the treating physician. And, is it, what's the risk of the x-ray, relative to the chance that there's going to be a clinically significant finding on the x-ray, such as curve progression. And so it's hard for us to say, no, she doesn't need it. It's a tricky thing. Now we're developing, and it should be FDA cleared soon, a tool to quantify the scoliosis on a smartphone at home without radiation. So in several months, you'll be able to follow it closely without getting an X-ray from home. And so, but prior to that, we're still relying on X-rays to accurately determine the curve, progression and situation. So, tough for us to kind of override, your surgeon's recommendation. It's certainly reasonable. 15 in girls are often skeletally mature, and so I generally would agree with you that it is unlikely she's progressing. But unfortunately, there's no good way to tell yet without getting an X-ray. So not really maybe a great answer.
I have nothing else to add there. Good.
How about this one? So another question, John, when taking stress films in the brace, how long should the brace be off before in and out of the brace? So maybe a nuance, and I don't know, Jesse, if this is more of an X-ray tech issue, but if you have any thoughts on that.
They generally, I don't know, that's like a tech, but that sounds like a tech question. That's a very good question though. From talking to them, and one of my close radiology partners is involved in charge of the X-rays and tech training, and they usually come to clinic in the brace oftentimes, because I think oftentimes the parents think they should be in brace. It kind of depends on what your orthopedic surgeon has advised you, like should be the brace on all time or at night. So they just continue following those questions, those recommendations. But that's actually an orthopedic type question. Does it change rapidly when you take the brace off? And I'm not 100% sure about that.
Yeah. So yeah, I agree. So it generally, we think it's somewhat of an immediate shift. There is some soft tissue laxity that comes into play. So 10 or 15 minutes is generally seen as appropriate to kind of let the ligaments and the deformity settle back to its baseline with the braces out.
Yeah, thank you.
Aviana, so I know you're open to various treatment options, including non-surgical approaches like physical therapy and bracing. So absolutely. So this is one of the, I think, the driving forces behind the National Scoliosis Clinic. So historically, the concept was X-rays and waiting and watching, and then you hit a threshold, and now the recommendation is a brace. And so many parents are frustrated with just having to wait and feeling like they're just at the mercy of whatever the natural history is going to be. So there is some great new data and evidence out there that non-operative treatment, we know bracing works when applied early and worn enough hours in the day. But we're actually focusing a lot on some scoliosis specific Schroth therapy and also Pilates type exercises for which there is good evidence that it helps. And so one of our main focuses is directing patients towards scoliosis exercises, again, to be a little proactive and give your child the best chance to avoid progressing that curve to the point where it might need surgery. Let's see, health insurance at Stanford. Yeah, Stanford takes a bunch of insurances for Sherry. Let's see what else. Yeah, may you tell me how to know the X-ray front or back so I will know right or left side of my body? I think this is kind of a basic, Jesse.
Sure, let me reshare my screen. So that's a good question. So when you're viewing your child's imaging, all the images should be marked. So we have a label. Oftentimes as a radiologist, we view all the images backwards. Like we're looking at the patient looking at me. So do you see this little R here? That's marked as this is the right side of the patient here. So when I'm looking at it, this is the right side, left side. Now, when you're looking at images generally with your orthopedist, they will flip the images. They'll look at the image, how they'll look at the patient during surgery, more or less. So this should be marked. And on a lateral, sometimes it's not, but let's see. Go back to my lateral. So oftentimes they won't label it, but you could just look and you see if you can see their face there, or the arms pushing forward, so that you could kind of tell from the lateral view there.
Yeah, totally. Another question. So this comes up a lot, actually. There's many adults that have been in touch with us about their scoliosis, and what are the issues with with bracing and stabilization. So scoliosis in adults is a little bit of a different situation. It's not as prone to progress like in adolescence. So in adolescence, the goal is to brace early to prevent progression of the curve until the point that they hit skeletal maturity. Adults have a more static, non-changing scoliosis, except when they start getting degenerative changes of the spine. And then the scoliosis can progress due to degeneration, which is essentially like arthritis in the spine. So braces in adults are used very differently, and I would say much less commonly. The goal is not to prevent progression, but more to provide some symptomatic relief. And then, as you may know, there are a lot of other ways to provide symptomatic relief to a spine that's getting some arthritis with, hot packs and cold packs and anti-inflammatories and things like that. So maybe we'll just one more here. Rashanak, should we suggest to our doctor to get a bone age of the wrist to see before getting x-rays of the spine over and over again? So I think that's a reasonable idea. And I think most treating physicians, whether it's a pediatric orthopedic surgeon or a pediatrician, take into account the skeletal age of the patient. And like Jesse gave just a great overview on the ricer or the hand. There are other ways to assess. Sometimes age is just it's a good surrogate too, but I think it's reasonable to make sure your physician is accounting for the skeletal age of your son prior to getting a bunch of x-rays. So we're about 45 minutes in. Maybe we'll wrap here. Thanks so much to Jesse for participating. This is extremely helpful. We'll send out the recording. Really some just high-yield, succinct, clear information that's really helpful. Come visit us, nationalscoliosis.clinic.com. We've got a ton of live sessions, good information, visits with doctors, soon to be home assessment of scoliosis without radiation. And so we're really excited to help a lot of patients get information, proactively treat their scoliosis, and again, eventually diagnose and monitor from home. So thanks again for joining, everybody. Thanks, Jesse. Can't thank you enough. That was just awesome. And we'll see everybody soon.
Thank you.
Take care.